participants. My name is Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet, and it's my great pleasure to welcome you on behalf of the European Hematology Association and the ERN-EuroBloodNet to the second webinar of the program called EHA and ERN-EuroBloodNet Spotlight on Castleman Disease, that is an accredited European online educational program that targets health professionals and is organized by the EHA and the ERN-EuroBloodNet. As you may know, this program consists of 4 sessions, all focused on Castleman disease. It is accredited by 4 continuing medical education points of the European Board for Accreditation in Hematology. So each session is 1 credit, and you can both follow the full program, so get 4 credits, or require only 1 credit associated to the lecture you have assisted. For getting those points, we have some rules to follow, so please pay attention that you have insert your full name and surname in the Zoom platform. And also at the end of the session, you are going to receive a survey. It's a very short one, but it's mandatory to answer in order to get the accreditation, because this is a way for us to track your presence. So before starting, still some house rules, some technical information. As you may have noticed, this session is recorded because it will be implemented in the EHA and EuroBloodNet e-learning environment. So if you don't feel curious about that, please put your camera off and be kindly informed that your microphone will be muted along all the lecture. If you want to address questions or comments, feedback, you can write them in the chat, and they will be addressed at the end of the presentation during the Q&A session. So now we arrive at today's lecture. So we are going to talk about Unicentric Castleman Disease. The lecture is provided by Professor Eric Oksenhendler. And we are going to see the imaging, the diagnosis, initial assessment, complication, pathophysiology, and treatment. So dear audience, please welcome with me the speaker of today's session, Professor Oksenhendler. For introducing him, he's Professor of Clinical Immunology and Head of the Department of Clinical Immunology in the Hôpital Saint-Louis in Paris. He's head also of the French Reference Center for Castleman Disease, and he's involved in Castleman disease clinical care and science since the 1990s. In 2012, he joined the Castleman Disease Collaborative Network and became a scientific advisory board member, mainly involved in clinical care. So please, Professor Oksenhendler, the floor is to you. Thank you very much.
Thank you very much, Angela, for this kind presentation. So welcome to this session. This is the second session, and the focus today will be the unicentric form of Castleman disease. So as said, we will review some aspects regarding imaging and pathological features, and then recent insights on the pathogenesis of this disease, and finally the clinical management and treatment. So here are my disclosure, and none of them are relevant for the topic today. So let's go back to the first description. I'm sure you are already aware of this, but still I would like to acknowledge Benjamin Castleman, who was a pathologist in Boston, and he was also an editor of the New England Journal of Medicine. And in 1954, he had to discuss a very special case. It was a 40-year-old man who presented with a mediastinal mass that was initially suggestive of lymphoma or thymoma. But when he looked at the pathology, he described something very different. It was not a tumor. It didn't look like a thymoma, and it didn't look like lymphoma, but the feathers were quite different than what could be observed in a normal reactive lymphadenopathy. And at that time, during the presentation, Dr. Chapman said, this is a new disease syndrome that you are presenting to us. And I get that Benjamin Castleman was convinced, since in the following 2 years, he gathered 13 new cases and described the disease, which we know now as Castleman disease, but he described the unicentric form of Castleman disease, and this was due to the bias he used, as he just gathered cases of unique mass presenting in the thorax. So let's go now for the diagnosis. Well, UCD is usually observed in young adults, but also in children. It could be diagnosed by self-examination or incidentally using imaging performed for another purpose. Usually it affects the chest, but also the cervix, the abdomen, or peripheral areas also. And most important, it's usually asymptomatic, except maybe in the very large mass that could be compressive and have associated symptoms with this compression. Most importantly, inflammatory symptoms are usually absent. No fever, no weight loss, no biological symptoms of inflammation. And last, in very rare cases, the diagnosis is performed after a diagnosis of complications. And we will come to this later on regarding the complications of this disease, possible complication. So here is the typical form of unicentric Castleman disease. As you can see, it's just usually a solitary lesion. It could be a big lesions. The median observed is 6 centimeters. It's a clean-cut lesions with clean-cut margins. You can see that. And when we use a CT scan, you see that on non-enhanced CT, you have a uniform density, and sometimes, and this may be useful for the diagnosis, microcalcification with central distribution, and the radiologists know that. And on the contrast enhanced CT, we have a very significant enhancement, both in the arterial phase and a continuous enhancement in the portal phase. And this is because these lesions is a hypervascular lesions, and it provides these hypervascular shining aspects on the CT scan. And a good radiologist, I must say, could even suggest the diagnosis when he sees such lesions, combining these microcalcification, the clean-cut margins of these big mass, and the shining aspects and the hypervascular aspect of the lesions. And that might be important when we will discuss which kind of biopsy we should perform in such cases. But still, it's not always as simple. In most cases, we have a single mass with smooth margin, but sometimes the margin might be somewhat irregular or lobulated. However, in these cases, the resection is usually easy and the surgeon is comfortable with these kind of lesions. And the pathology will be always of the classical Yelling vascular type. But in other cases, you can have a single invasive mass with blurred margin or even multiple fused masses. And you easily understand that in such cases, the complete resection is not always possible. So proportion, sometimes a high proportions of patients will have only a partial resection of the lesions. And interestingly, in these atypical cases, the pathology is not always of the hyaline vascular type, but sometimes, usually less than 20% of the plasma cell type, plasmacytic type. So let's come now to the histopathological diagnosis. This is a Castleman disease as seen by Vincent van Gogh at the end of the 19th century. And this is what we can see now. I know you have already seen the pathological aspects of Castleman disease during the first webinar, but I will just like to point out a few aspects. Probably the most important are the lesions on the germinal centers. You've got atrophic germinal centers, sometimes with 2 or even 3 germinal centers in a single follicles. And then you have these well-known feathers of concentric layers of the mantle zone cells, providing the so-called onion skin feathers. And then you have the abnormal follicular dendritic cell network. And finally, but this is a very important point in the diagnosis, the vascular lesions with hyalinized vessels. So just to summarize, abnormal germinal centers is the most prominent feathers with atrophic GCs, abnormal FDC networks, sometimes follicles containing 2 or 3 more GCs, and then the vascular lesions with hyalinized penetrating vessels associated with interfollicular hypervascularity, the typical onion skin feathers, which is secondary to large concentric layers of mantle zone cells. And we will see these later on, variable interfollicular plasmacytosis. So when this diagnosis is suggested, we have to review at least 3 points. The first one is to carefully review what the pathologist says and to review the lymph node pathology. So the pathologist will ideally grade all the lesions and be able to classify these lesions into 2 major types. The hyaline vascular type, which is by far the most frequent in UCD, observed in about 80 or more than 80% of the patients, with atrophic GCs, onion skin, mantle zone, and hypervascularity. And on the other edge, the plasmacytic type, present in less than 20% of the patients, where you can find hyperplastic GCs and interfollicular plasmacytosis, which are not really pathognomonic of this disease. This could be observed in many other diseases, as you will see when we will discuss IMCD in the next webinar. Second reason to review the lymph node pathology is to be sure that there is no differential or associated diagnosis. The most important is probably FDCS, follicular dendritic cell sarcoma, which is a proliferation of spindle cells, usually arranged in a fascicular or storiform pattern. And this disease is a tumoral disease, is a sarcoma, which could be present even at the diagnosis of Castleman disease. So you can have both lesions in a single lymph node, lesions of Castleman and lesions of FDCS, or it could be the prominent feather observed initially or in the follow-up of the disease. The second diagnosis is plasmacytoma or low-grade lymphoma. And this is important to discuss when you face a case with intense plasma cell infiltration in the interfollicular area. The plasma cells looks usually normal, but still you have to systematically perform immunohistochemistry, both for the heavy and light chain, And you can see in this case, for example, monotypic restriction of the expression of the surface immunoglobulin, in this case, IgA lambda. Second point to review is imaging, which could be CT, MRI, or PET-CT. In the classical cases, the Unicentric Castleman disease, you've got only one single lesion, as we have already described previously. But in some cases, you have multiple adjacent lesions in the same lymphoid region. When we say same lymphoid regions, it refers to the Ann Arbor classification. And these cases are today classified as oligocentric or regional Castleman disease. And the third point is to look for possible inflammatory markers, both clinically and biologically, or complication. So the symptoms are usual symptoms, B symptoms, fatigue, lymphadenopathy, splenomegaly, that could suggest diagnosis of lymphoma. And complication, the most important complication to know is paraneoplastic pemphigus. So we have straightforward to look for skin lesions, oral lesions, or even respiratory symptoms in these patients. When we look at the classical workup at diagnosis, you can see we need only a very limited number of markers. The classical blood counts, inflammatory markers, including serum protein electrophoresis with immunofixation, liver test, ferritin, kidney function, and proteinuria. And then here you have two markers for the most frequent complication, antidesmoglin 1 or 3 for PNP, and anti-choline receptor antibody for myasthenia gravis. And then you may have to use other markers, but mainly in the cases where you are discussing possible differential diagnoses, such as IgG4-related disease, lupus, Sjögren, or plasmacytoma. But I must say that this is mainly a problem when we deal with a presentation suggestive of idiopathic multicentric Castleman disease, and it's not really the case for UCD. So this is usually absent, and the blood tests are usually normal or negative. Here is the series of patients that have been followed in our reference centers. So these provide data on a little bit more than 100 patients. You can see that we have equally male or female patients, that the median age for diagnosis is around 40 years, that you have 3 major sites for this disease, the mediastinum, abdomen, and cervix, but also peripheral lesions are possible, that usually we have no associated symptoms, but still, in a few cases, you can have inflammation, fever, splenomegaly, or here the skin and lung lesions are mainly associated with PNP. And then the bio, well, the blood counts are normal, the biochemistry is usually normal, the gamma globulin level is normal, but still, in around 20% of the patients, you have inflammatory markers as suggested by an elevated serum CRP. So this is the picture of the general population with UCD. And then we have these gray zones. The first one we have already talked about. This is the case of the patients with several lymph nodes in a single area. These patients are usually considered as UCD, even if the problem, the treatment problem will be tough for the surgeon sometimes. And the second gray zone, is relative to the patient who have not the classical hyaline vascular type, but rather the plasmacytic type or a mixed type. And in such cases, we have often symptomatic disease with inflammation, failure to thrive in the children, or autoimmunity. So how could we classify these two gray zones? Well, we can try to compare them to the classical type. If we look here on the differences between the single lesion and the single station cases, you can see that they are very similar. There is no difference in the clinical presentation, no difference in the bio, except maybe for a higher percentage of patients with inflammatory symptoms in the regional or oligocentric form of UCD. And we observed something very similar when we compare the patients with the hyaline vascular type to the patients with the plasmacytic type or mixed type. Very similar clinical presentation, very similar bio, but here, again, a very high proportion, more than half of the patients with bio-inflammatory markers, as suggested by an elevated serum CRP. So at that point, we have three possibilities. The first one is the classical type. You've got a hyaline vascular pathology, a single lesion, the patient is asymptomatic, and you can go for surgery straightforward. This is very easy. And I would say that more than 2/3 of the patients will fall in this category. The second one, you've got these UCD, but you have a plasmacytic histological type or clinical and biological symptoms of inflammation. And this is very interesting because we don't know yet if we should still consider these patients as UCD, or at least for the treatment, consider them as localized IMCD, which is an oxymoron, I know, but we can think about a primary disease such as IMCD that could be somewhat localized. And in these cases, surgery is still an option. We can cure this patient if we can obtain a complete resection of the lesions. Otherwise, these patients could benefit of a treatment usually used for IMCD. And the third category is the regional cases or cases associated complication which will require a specific management. We will see that thereafter. So let's go now for the complication, PNP. So PNP is an autoimmune disease characterized by the presence of autoantibodies, mainly anti-desmoglein antibodies that are able to disrupt the cohesion between the skin cells. So it's associated with blistering on the skin, oral ulcers that could be confusing for diagnosis. A number of patients will stay months or years with a potential diagnosis of aphthous or even Behçet disease. But the most important is that these autoantibodies react also with the epithelium of bronchi and may lead to a devastating disease affecting the lungs with important symptoms and usually non-resolutive symptoms. So this is really a complication to know. These lesions could be more frequent in China. When you look at the Chinese series of UCD, which are very large series, you see a very high proportion of PNP, peaking with 30 or 40% in such series. So we don't know yet if there is a genetic predisposition in this population or just a bias, as we know that most of the cases of this series have been first referred in dermatological ward. However, in all cases, nearly all cases, PNP precede UCD diagnosis. So it's a patient who presents with skin and mucous lesions, sometimes a severe lung disease, bronchiolitis obliterans. And then at that point, when the PNP diagnosis is done, we have to look for a lesion of Castleman disease. It looks probably more frequent in stroma-rich hyaline vascular UCD. That means lesions where the proliferation of the trauma cell is important, or even in FDCS. And in the context of FDCS, the PNP complications are very frequent. So this will be important to know when we will look at the treatment, as an intensive specific therapy is required before the surgery of Castleman lesion. Still, PNP is the major complication, but we can also observe other complications such as myasthenia gravis, autoimmune cytopenia, and nephropathy, which is usually a glomerular nephropathy, such as thrombotic microangiopathy. And of course, there are a number of single case reports reporting on anecdotal complication associated with Castleman. Let's come now to pathophysiology. The first and probably the most important question is, are we facing a clonal disease? So we have a number of data to try to answer this question. The first one, we have no B-cell receptor or T-cell receptor rearrangement disclosed in the UCD lesions. And this has been done in numerous series. There is no evidence for clonal lymphoid B or T-cell lymphoid proliferation. But still, we have clonal cytogenetics abnormalities in stromal cells culture. And we have also evidence for clonality when we use a Humaret technique that could be performed on non-lymphoid cells. And as you can see, the vast majority of the patients with UCD were shown to have a monoclonal cellular proliferation. And this was correlated with the tumor size and the stromal proliferation. Recently, a group has published transcriptome analysis of UCD and compare the results to reactive lymph nodes. I would just like to mention that this analysis has been performed as a bulk analysis on whole lymph node. We don't know on which cells are responsible for this signature. But still, there are interesting data showing an upregulation of some proteins or chemokines. Briefly, we have an upregulation of APC markers, such as CXCL13, angiogenesis factors, extracellular matrix remodeling factors, complement components, and GC activation markers. And this fits very well with what the pathologists see. So here we have another paper, UCD and IMCD, and you can see that the major genetic abnormalities were observed in UCD lesions and mostly affected the MAP kinase pathway and the interleukin signaling pathway. And last, a group from China has shown that in nearly 20% of patients with UCD, they were able to disclose a recurrent mutation on PDGFR-beta in the lesion of Unicentric Castleman disease. And this is very interesting because it's a missense mutation. It's always the same mutation. And this mutation is a gain of function mutation with activation of the receptor kinase activity. This mutation may be associated with transformation of fibroblasts. And more important, they could show that this mutation was present in CD45 negative cells. So that was not in the lymphoid cells, and it points again the possible involvement of FDC or an FDC precursor. And this, of course, is very interesting. As you know, we have some inhibitors that could be effective on PDGFR-beta. So we are working on this. This is what we are currently doing in the lab, starting with fresh lymph nodes for classical microscopy, but also tissue dissociation and cell enrichment to study the FRC and go for single cell RNA sequencing and culture, and we will go for validation at a protein level. So this is currently ongoing in our lab. Now, the final point is treatment strategy for UCD. So as you have guessed, the best treatment is surgery. And when the surgery appears to be easy for the surgeon, go straight forward to the surgery and you will get cure in more than 90% of the patient. But still, it appears that only around 70% of the patients can go straight forward to surgery. In other cases, the surgery is not so easy or described as possibly invasive by the surgeon. So in such cases, one option could be wait and watch. So what is the evidence to approve these options? Here is the case of a 13-year-old boy seen in 2005 because his mother thought he was hunchback. So he underwent a chest X-ray, and the radiography revealed a solitary, well-defined mass in the mediastinum. At that time, he had no symptoms, normal blood test, and a biopsy, transthoracic biopsy, revealed a diagnosis of Castleman disease, Yalin vascular type. But the surgery was really difficult because the lesion was on the arterial pulmonary arteria, and the mother of this boy said that she preferred her boy not to be not to undergo surgery. And I saw this boy 14 years later. At that time, he was handsome, as said by his girlfriend. And as you can see, there was no progression at all regarding the volume of the mass. The chest X-ray was really exactly the same than 40 years before. And he has still no symptoms and normal blood test. So yes, definitely wait and watch is a possible option in such cases. Otherwise, we may try to reduce the size of the tumor, thinking of a more easy surgery thereafter. So a number of drugs have been used: steroids, cyclophosphamide, rituximab, cetuximab, sirolimus. And I must say that all these drugs are really, or all these approaches are really disappointing in reducing the size of the tumor. Another option is embolization. So we have seen that UCD is a hypervascular tumor, as you can see on these pics, with a vascular blush and a vascular recruitment of a large vessel. So we can think about embolization after a careful analysis of all vessels collection, before embolization, of course, and the use of small particles to occlude the vessels. And interestingly, this procedure can be repeated. So this procedure can be used pre-op for the surgeon to have a less hypervascular lesion. Could be hemostatic sometimes, even in pair-op, or as a single treatment for the lesion. Last option is radiation therapy. Radiation therapy is effective in about 75% of the cases, but still, this is the last option because we are reluctant to deliver radiation therapy for a lesion which is not a cancer, which affects usually young people and mainly in areas with possible secondary complication, such as on the thorax, regarding the breast, the risk of breast cancer, the risk of fibrosis on the coronary arteries, etc., etc. So this is really an option that we try to avoid, but sometimes we have to do it. As I previously said, there is something to know about treatment of UCD and PNP because there is a risk of severe PNP flare following surgery. This is also the case after radiotherapy. And so to prevent this flare, we have to propose an intensive treatment of PNP just before surgery. And this treatment usually involves steroids, IV immunoglobulin, and/or rituximab. So here are my tech hospital messages. We have seen that this disease is usually asymptomatic, except the case where the single mass is compressive. We have seen that we can define peculiar signs on imaging that could be suggestive of the diagnosis. And this is very important because if the radiologist says that really it looks like UCD, you can go straight forward to resection surgery and not just a single biopsy. We have seen that we systematically have to look for a diagnosis of PNP, but usually it's the other way around. You have the diagnosis of PNP and you must look for Castleman disease. The standard blood tests are usually normal, but we also have seen that you have a subset of patients, mainly patients with plasmacytic type with inflammation marker. The surgical biopsy on the complete resection should be preferred if the diagnosis is suspected, and it will confirm the diagnosis on the pathological examination. Regarding pathogenesis, we know now we have a number of data converging towards a clonal disease of FDCs or FDC precursor, with the evidence of somatic mutation in TGF-beta gene or associated pathway. And we have also seen that the wait and watch option is possible in some cases that remain asymptomatic. So as many hematological disease, we need a multidisciplinary approach. So this is why I have with me David Boudboul on the piano, Claire Fieschi, cycling, Marion Malfait, taekwondo, Lionel Galissier, deep diving, Laurent Gérard, triathlon, Jeanne Fadlela, yoga, and I'm more than happy to run that group. Thank you very much, and I'm ready to answer your question. You can ask your question using the chat or ask for a direct oral question if you wish also. Thank you very much.
Thank you to you, Professor Oksenhendler. I also encourage the audience to write a question in the chat or also to, yes, I can see Professor Brown. Now you should be able to unmute yourself.
Thank you for, hello. Thank you for this nice overview. I have a few questions, and you said that 20% of the patient presented with an inflammatory biology. Is that predictive of something? Is that worse prognosis?
Yes, thank you for this question. Well, 20% is probably a maximum, but still in this patient, especially when on the pathology, there is also a mixed type or plasmicity type of the disease. This is predictive of a higher rate of recurrence of the disease after surgery. That's true.
Okay, and another question is, you have nicely shown that some angiogenic factors are upregulated, but you didn't mention lenalidomide, for instance, in the treatment. It was already tested?
It has been, to my knowledge, it has been tested mainly in IMCD and mainly in China, where this drug is available and some other drugs are not. To my knowledge, it has not been used in unresectable UCD, but it could be an option also to test.
It could be an option with angiogenic factor. And the last question is, you have some form with clonal disease of the FDC, and then even if when you have a clonal disease, it's not a tumoral disease?
Yes, it is, but
because you said it's not a tumor.
Yes, yes, it's, you know, this is almost a Talmudic discussion when where we are talking about somatic mutations. Yeah. So yes, probably, but the point is that I am not sure, for instance, when we see that the major complication locally in the lymph node could be FDC sarcoma, I'm not sure that the FDC sarcoma cells will harbor the mutation. There is probably something in the stromal cells which are dysregulated, probably in association with some somatic mutation or constitutive activation of some pathway. But yes, you can say this is a tumoral disease, but the major feather that we see is probably just the consequence of a few dysregulated cells. So
okay, yeah, it's debatable. Yes. Yeah. Thank you so much. Very clear presentation. Yeah.
Thank you very much. I have a few questions on the chat. The first is, what do you think of the role of EBV? So the answer is, it's clear enough. There is no role for EBV at all in this disease. It has been looked for using many techniques, and even if, as any reactive lymph node, you can spot a few EBV positive cells, I think there is no role for this virus in UCD. The second question is the association of Castleman disease with HIV and how deal with such situation. I would say that Castleman disease, which is observed in HIV, is almost in all cases associated with the KSHV or HHV8 virus. And you will see that in the fourth webinar in 4 weeks from now. But still, we have observed a case of UCD in an HIV-infected patient. So HIV do not prevent the possibility of getting UCD, but I think there is no direct link between these two pathology. Third question is, would you do PNP prophylaxis in case of gray zone patients? How would you do it? Steroid versus immunoglobulin versus rituximab? No, we don't do PNP. Well, we usually do PNP prophylaxis, which is not prophylaxis, in the cases with a PNP diagnosis just before surgery or radiation therapy. A more difficult question would be, what would we do in patients with classical UCD, which is usually not of the belonging to a gray zone case? What would we do if in this patient we find antibodies against antidesmoglin 3, for example? So if we have biomarkers of possible PNP in the absence of clinical symptoms. So I'm not sure I can answer this question. I will probably suggest some kind of prophylaxis, or to be really aware of possible flare, that would not be a flare, but just an occurrence of the clinical disease after surgery. And I have no personal opinion on the choice of just steroids versus immunoglobulin or rituximab. Yes. Which immunohistochemistry markers we should do on lymph node biopsy of Castleman disease? Well, I would say that when the pathology is really of the hyaline vascular typical type, you don't need much. You can just use markers to reassure what you see. That means that the FDCs are FDCs, that the B cells are B cells, T cells are T cells, etc., and there is no plasma cells. When we have plasma cell infiltration, I think we can go for further immunochemistry. As I said, first of all, to be sure that the plasma cell is not clonal, using immunochemistry or molecular biology, and also to disclose a possible associated diagnosis, which is lymphoma, and mainly Hodgkin lymphoma. But so for this, you will have to use CD30, CD15, for example, and also an ABV marker. But I must say that this differential diagnosis is mainly an issue when we deal with a presentation of multicentric Castleman disease. It's not the case when the presentation is a solitary mass. So we need very few markers.
We have one hand raised by Christopher. I'm sorry I called you by your name, but I cannot see
No,
the
thank you.
surname.
No, yeah, thank you. Sorry, Professor, thank you for the great presentation. I was just wondering, I did a question on the PNP prophylaxis, but
Yes.
in your case, when the patients do have PNP, which of them do you prefer? Do you prefer the...
Okay, we do the three.
Okay.
Okay, usually when we see the patients, they are already on steroids given by the dermatologists. And we propose at least one infusion of rituximab and IV immunoglobulin just before surgery. And I must say that we have faced this kind of case recently, and we have not done the rituximab because of the COVID epidemic and the possible complications. So we just went for steroids and IVIG, and it did well.
But I'm asking is because I have a patient in this situation. So if, for example, if he didn't have the antibodies, so if he didn't have the desmoglein antibodies, would you do it either way or not?
No.
Okay, so I should ask for the first. Okay, perfect. Thank you very much.
Thank you.
Well, waiting to see if there is one additional question. I can suggest you to follow the next webinar, so the third for this program, that will be led by Dr. Simone Ferrero, who will have a lecture on idiopathic multicentric Castleman disease on the 15th of February, so in 2 precisely weeks. And as said at the beginning, all the lectures will be implemented both in the e-learning platform of the EHA and of the ERN-EuroBloodNet. Okay, so I see no more answer. I think everything has been addressed. So I would like to thank, first of all, the speaker, Professor Oksenhendler, for having shared with us his time and expertise, most of all, and then to the audience for being here and also for the debate had. So thank you very much. I wish a nice evening to all of you and see you in 2 weeks. Thank you.
My pleasure. Thank you.
Bye-bye.